which means that we're shifting gears now from just simply coronary artery disease discussion to more of a heart failure multidisciplinary team discussion. My task is to discuss mechanical circulatory support in patients who end up with cardiogenic shock, which was a nice ending to the previous presentation, and decide whether or not these patients could benefit from mechanical circulatory support. So I'm going to go through some definitions in pathophysiology of cardiogenic shock. I'll talk a little bit about hemodynamic monitoring because it's always a contentious issue. I'll discuss selecting the right form of support, and then I'll say a few words about the shock team concept. So cardiogenic shock, as you all know, is the reduction of cardiac output resulting in hypoperfusion. In hemodynamic terms, it usually means a reduction in cardiac index to less than 2.2 liters per minute per meter squared with vasoactive medications, or less than 1.8 without any vasoactive medications. Of course, usually associated with a blood pressure of less than 90, but not always. And this happens generally with normal or elevated pulmonary capillary wedge pressure as a sign of increased filling pressures. Unfortunately, mortality with cardiogenic shock after MI did not really change over the years. It's still very high in hospital mortality, approaching 50% even at advanced centers. What we know today that we didn't know before, and similar to the evolving pathophysiology of coronary artery disease on unstable plaque and moving from the vulnerable plaque to the vulnerable patient, we now know that cardiogenic shock is not just simply a mechanical phenomenon. Yes, it starts with a reduction of cardiac output, as you see on the screen, but it actually ends up with not just vasoconstriction because of low blood pressure and resulting hemodynamic changes, it also results in a significant cascade of inflammation that leads to more vasodilation with time, bacterial translocation, and other systemic inflammatory response features. The Society of Coronary Angiography and Intervention classified cardiogenic shock in this easy-to-remember classification from A to E to help you decide what kind of shock the patient has at the bedside and decide when and how to intervene, with A simply being at risk for having cardiogenic shock. B is just the beginning of cardiogenic shock, and what I mean by that is somebody who is hypotensive but not necessarily hypoperfusing. And then C would be somebody who is hypotensive and hypoperfusing. Of course, you have to look at things like the clinical features, but also the change in laboratory findings like the serum creatinine, the lactate rising, and of course, if you have hemodynamic measurements, it would be reduction in cardiac index and other hemodynamic parameters that I will discuss with you in a little bit. D would be C, but deteriorating, basically getting worse. And then, of course, E is the patient who is about to arrest. This is the patient who's trying to die on you in the ICU or in the cath lab. I wanted to spend a minute on this slide because it's very important. In classic teaching, we always remember that cardiogenic shock means vasoconstriction. The reduction in cardiac output, that means increase in vascular resistance to make up for the reduction in blood pressure, because as you know, the blood pressure is a function of cardiac output and vascular resistance. If the cardiac output drops, the vascular resistance will have to increase. That's true in the initial phases of shock. But as the shock progresses into the systemic inflammatory response stage, that vasoconstriction starts to become more of a vasodilation, or what we call the paralytic vasodilation. This is where you need to intervene and remember that just simply using medications may not reverse this clinical picture, and that intervening with mechanical support may actually make a difference in the patient's overall outcome. Okay, I wanted to talk about the PAA catheter because this is always a point of discussion between especially cardiac and non-cardiac intensivists. But we find as cardiologists working in cardiac ICU that the PA catheter can be very, very helpful in a lot of scenarios. It can differentiate cardiogenic shock from other causes. I can't tell you the number of times that I was called to evaluate a cardiogenic shock patient, and then with hemodynamics, we concluded that the patient is actually in septic shock, not in cardiogenic shock. It can unmask cardiogenic shock in hypoperfusing patients who are still with a blood pressure of more than 90 systolic. It can accurately determine the filling pressures. It assesses the right-sided involvement. It will decide if the right ventricle is involved or not involved. And then it guides the use and weaning of mechanical circulatory support if you choose to use that. And of course, it helps select best candidates. In this large database from the US, more than 150,000 patients, the use of pulmonary artery catheterization in cardiogenic shock resulted in less readmissions to the hospital and resulted in better use of mechanical support. So these patients ended up with more extracorporeal membrane oxygenation support as well as more LVADs. Let me introduce a couple of important hemodynamic parameters. If you leave this lecture with just these two important hemodynamic parameters, I will feel like I won. The cardiac power output is simply the MAP, mean arterial pressure, multiplied by cardiac output divided by 451. Very simple formula. If this is less than 0.6, you know that your patient is in trouble. Again, if you remember this, you will know if the patient is in persistent shock or is actually improving from a cardiac standpoint. That's one formula. Of course, there are many hemodynamic parameters to assess, but if you're worried about the RV in particular, always look at your central venous pressure compared to the wedge pressure. If it's more than 2/3 of the wedge pressure, the natural relationship is that the CVP is half the wedge. But if it's more than 2/3 of the wedge pressure, then you know that the RV is probably not doing its work. The pulmonary artery pulsatility index, PAPI, is simply the pulmonary artery systolic pressure minus the diastolic pressure divided by the central venous pressure. Again, this is a very important formula to remember for the RV, systolic minus diastolic for the PA divided by right atrial pressure. If this is less than 1, you know that the RV is in big trouble as well. Okay, what are the forms of mechanical support that we usually consider? You have the intra-aortic balloon pump, you have the Impella, which are catheter-based support. Tandem heart is used in certain centers around the world, and then of course, ECMO. So the balloon pump, as you know, augments the diastolic blood pressure. It's a very commonly used support system. It enhances coronary blood flow and it stabilizes patients, especially when they have inadequate coronary perfusion. It's relatively cheap technology. It improves coronary perfusion, but importantly, it had negative studies. So this is the SHOCK 2 trial in acute MI with 600 patients, and using the balloon pump in this case in patients with acute MI and cardiogenic shock, 2/3 of them were STEMI, did not result in improved outcomes, not at 30 days and not at 1 year. The Impella is a catheter-based system. It's like a pigtail. As you can see, it goes into the left ventricle with a motor that kind of propels the blood distally. Here, basically sucks blood out of the ventricle and then sends it distally. It improves the cardiac output and it improves hemodynamics. So this was just to show that the Impella actually increases cardiac output and reduces pulmonary capillary wedge pressure. However, in comparison with the balloon pump in acute MI trials, there wasn't a clear benefit in the small randomized studies that were done. But we know that it hemodynamically actually adds significantly more than the balloon pump. Some of the complications are primarily related to limb ischemia because of the size of the catheter, but hemolysis, because of that motor working to propel the blood distally, can actually be significant, up to 15% in certain cases, and it depends on the speed that you're using for the Impella. ECMO is the more robust form of support. This is when you do it peripherally and cannulate the femoral artery and femoral vein. You have the pump outside, and then you're propelling blood back to the heart in a reverse direction. As you can see, this is the pump here. Now, this is the arterial, this is the venous outflow, this is the arterial. The problem is that you're pumping the blood in reverse direction to the heart. Now, this just primarily has the issue of increased afterload on the heart more than anything else as a disadvantage. So to summarize these forms of support, Impella and ECMO will give you a lot more cardiac output support than the balloon pump. They will also improve the blood pressure more than the balloon pump. They will enhance the cardiac power output more than the balloon pump. The only difference between the Impella and the ECMO is that ECMO will tend to increase the afterload and filling pressures, while Impella will actually reduce it because it's sucking blood from the ventricle. That's why when we use ECMO, we use what we call an unloading strategy. We place either a balloon pump or an Impella at the same time of ECMO to unload that left ventricle and not allow the filling pressures to be too high from that reverse flow of the ECMO. And in this large retrospective study, it was shown that both the balloon pump and Impella work okay to unload the left ventricle. If anything, the balloon pump did here a little better than the Impella. Quickly on the shock team. The shock team is basically calling people to discuss the patient very quickly when there is a cardiogenic shock case. It's the cardiac intensivist, it's the cardiac surgeon, it's the interventional cardiologist, it's the heart failure and transplant cardiologist. They quickly diagnose, characterize, and classify shock. They adjust vasoactive medications. They decide on hemodynamics, and they decide on mechanical circulatory support. And if we're seeing any progress in the management of cardiogenic shock in the recent years, at least based on single center data, they're based on the fact that the shock team concept is now being implemented. It seems that it's not just simply the management that you do for the shock patient that makes a difference. It's actually having a team approaching these patients and making the decision at the same time, as opposed to just an individual making that decision. So now these discussions should be happening even before the patient arrives, if the patient is in shock on the way, or if the patient is in the cath lab. All these people have to be activated and discussing the case, making the decision quickly. So take-home messages: invasive hemodynamics improve the management of cardiogenic shock when used in the right patient. When medical therapy is failing, mechanical support should not be delayed. For a single device support, the balloon pump minimally impacts hemodynamics. For more robust support, you need either Impella or ECMO. ECMO provides the most support of all percutaneous options, but it's of course the most invasive. Randomized studies are significantly lacking for all of these hemodynamic support options. Unloading or venting improves outcomes with ECMO. No evidence support anything more than the balloon pump in this case. Shock team makes a difference. Thank you very much.